Where is the cookie theft? A multifaceted clinical presentation and unique imaging findings in a case of balance syndrome. Balance syndrome is a clinical syndrome associated with bilateral parieto-occipital lobe lesions that disrupt connections between the prefrontal lobe posterior visual association area and motor regions. This lesion results in impairment of the hypothesized dorsal or where stream of the visual pathway, while the ventral or what stream of the visual pathway remains intact. Due to the dysfunction of the dorsal stream, balance syndrome is characterized by a triad of symlantic optic ataxia, and ocular apraxia. Symlantic refers to the patient's inability to identify multiple objects at the same time. Optic ataxia manifests as impaired reach responses through solely visual input, with preserved reach under proprioceptive or auditory guidance. Ocular apraxia manifests as the inaccurate saccades as a patient attempts to shift gaze from one to another. Our patient is a 49-year-old male with a medical history of well-managed HIV, hypertension, hyperlipidemia, and type 2 diabetes that presented to the ER on multiple occasions with complaints of new or worsening stroke-like symptoms. On his first admission, the patient complained of worsening blurry vision, non-radiating headache, and impaired depth perception. CT and CTA at the time showed a left occipital lobe infarct with high-grade intracerebral atherosclerosis. The patient was discharged in stable condition 2 days later, but was readmitted to the ER the following week for worsening symptoms, including new onset gait instability and left-sided weakness. CT MRI revealed mild worsening of cerebral stenosis, but were negative for new foci or changes from the prior occipital infarct. He was once again discharged in stable condition, but returned the following week due to new onset dizziness, generalized weakness, and a 7 out of 10 pain posterior headache. MRI and non-contrast CT of the head and neck parietal occipital junction infarct without hemorrhage and additional foci in the right temporal occipital lobe, the left half of splenium, posterior left thalamus, and anterior medial inferior left parietal lobe. Once stabilized, the patient was discharged from the ER for inpatient rehabilitation. He was able to steadily with the help of a walker, but repeatedly collided with objects in the room. On neurological exam, the patient was alert and oriented with slight difficulty following commands. His visual acuity was 20/800 in both eyes, with correction with notable right eye superlateral quadrantinopia. Additional findings include ocular ataxia and ocular motor apraxia. Further evaluation of visual deficits revealed the patient was able to properly identify commonplace objects such as a fork, spoon, and pen from 10 inches and 10 feet, but could not correctly identify the number of items when placed in a single hand. He could also identify colors but not shapes from the same distance. When presented with the Boston cookie theft picture, the patient could only identify the woman, but was unable to describe the image as a whole. When asked to draw a clock, the patient would begin drawing, lose the image, and restart his illustration until he gave up. The diagnosis of balance syndrome is reached with the following clinical findings. Optic ataxia, demonstrated by the patient's misreaching for an object, ocular motor apraxia via cranial nerve assessment, and symlantic nausea, tested via the Boston cookie thief. Additionally, one measure taken to rule out hemi-neglect, the most likely alternative diagnosis, was to have the patient draw a clock. As mentioned, the patient would start his drawing and then lose track of the image and reattempt, shown in Figure 3. This is not a reported finding in patients with hemi-neglect. Finally, Figures 1 and 2 are his imaging results in his initial and third admission, respectively. The third admission non-contrast MRI, in Figure 2, showed a new focus of acute stroke in the posterior right parieto-occipital lobe and anterior lateral mid-left cerebellar hemisphere. Additional foci in the right temporal occipital lobe and left half of the splenium corpus callosum, new punctate foci in the posterior left thalamus and anterior medial inferior left parietal lobe, evolution of basal ganglia stroke, and lack of consistent flow void in the intradural left vertebral artery consistent with occlusion. Though this patient only had a strictly right-sided parieto-occipital lobe lesion, we believe the damage done to his left side from his initial stroke was significant enough to produce balance syndrome. Balance syndrome demonstrates the key importance of neural pathways responsible for integrating visual stimuli and to optically understand and interact with the world. Damage to the visual cortex and parietal white matter can result in piecemeal experience of reality. Although balance has been characterized by damage to the bilateral parietal regions, several case studies have shown variations in these regional infarcts with resulting in the same syndrome. Future studies can address variations in neural pathways and psychoanatomical mechanisms involved into the integration of visual input. As others have suggested, visual working memory and also play a role in the clinical assessment of balance, and patients such as this one could be tested independently through other assessments, such as the digital symbol coding and spatial span test. Further analysis can be done with testing identification of object strength, structure, and depth. Completing an fMRI on this patient while having them complete visual recognition and integration would also be interesting to analyze any difference in neural management of oxygen supply and involvement of various brain regions. Thank you very much for your time.